Um, I'm Mike Rosenberg. I'm one of the cardiologists here at Froedtert South. We have a group of 7 cardiologists altogether, but 4 or 5 of whom do what we're going to be talking about, and we work in a rotation. So everything that you're hearing me say, please understand I'm speaking on behalf of my colleagues as well. So while this may be old news to some, it's, new to others. I'm sorry, I do have to take this. So while this may be old news to some of us, it's news to others, and it's important that we share some of this with our friends, because people make mistakes and we would like to avoid them making mistakes. Sometimes mistakes can be, God forbid, fatal. And in this circumstance, that is very important, and we'll talk about the details of that. So, first of all, let's understand what a STEMI is. That's an ST elevation myocardial infarction. That's the bona fide standard high-risk heart attack that occurs when an artery is closed and heart muscle is subsequently undernourished and potentially dies within about 20 minutes. And we're going to talk a little bit about what has been the case at Froedtert South in the past, what is more recent. When I say new, our program that we're going to be talking about is now 4 years old. The benefits, the quality metrics, and the outreach. So there's a lot of aspects to this, but let's first talk about ST elevation myocardial infarction. We recognize that by seeing a specific pattern on the EKG, and I don't expect to teach you how to read these, but the electrocardiogram here, we call, this isn't going to show very well, but we call the hump that you're seeing a tombstone. And that obviously tells a little bit of the story of what's important involved in that. That tells us that an artery is acutely closed. This process began in 2006. So this is an article from the Journal of the American College of Cardiology, and it was designed to establish a national protocol for how to treat acute heart attack victims. So until this article came out, people treated heart attacks in a lot of different ways, sometimes very conservatively, sometimes rest, sometimes you would electively take the patient to look and see what the arterial anatomy is like, and then make an attempt at opening up the anatomy. But the problem is that a heart attack is over pretty fast. Within 20 minutes of an artery being occluded, heart muscle dies. And the longer that wavefront continues, the more heart muscle dies, to the point where at about 3 hours, maybe even extended to 6, that territory is dead, and it will not be able to be resurrected. It's replaced with scar tissue. As a consequence of that, our goal is to act quickly. So we can only act as quickly as the patient makes us aware of. So if somebody has a heart attack in the field and dawdles and says, well, maybe this is going to go away, maybe we'll wait another 5, 6, 7 hours, I'll wait for my kids to come home. By the time that occurs, that heart muscle territory is dead and cannot be resurrected. So there's no way to restore that. Our goal is to get this done quickly. And if we can get it done quickly, meaning opening up that occluded artery, then we can restore heart muscle function and improve survival rates dramatically. And so that initiative began as a suggestion in 2006. You'll see my name as one of the co-authors of that. And that reestablished or established a national policy for this to occur. Looks like it's stalled. Okay. Thank you. You think it'll work now? We'll see. So our adage is that time is muscle. The longer we wait to restore blood flow, the more territory dies that cannot be restored. So our goal is to open up the artery. Typically, we do that with angioplasty. In an earlier era, and sometimes still, we use a clot-busting drug called a thrombolytic, which can dissolve the clot, but it does so variably and it does so slowly. So it's not as fast and it's not as complete and it doesn't always work. So we have moved away from the thrombolytics unless we don't have an option. And that becomes an important issue, let's say if you're in a remote area where there isn't immediate transport, or if you're in a hospital like ours where the team is already working on another patient and you can't find available another team to do the procedure that opens up the artery. That has happened here once in the 5 years that I've been here, so it's pretty uncommon. But basically, the heart attack, the onset is measured in one of two ways. It's either measured as first medical contact, which means the moment that EMS arrives at your doorstep, or as the door, which is the emergency room door when you arrive at the hospital, until such time as we open up the artery with a balloon in the cardiac cath lab. So this is an evolving national standard, and the expectation nationally is that from first medical contact to an open artery, it be 90 minutes, and from door to open artery be 60 minutes or less. That's the goal, because if you can achieve that, you can save lives and restore heart muscle function. So that is our goal. And as you might guess, that requires orchestrating teams. Lots of people have to get together and coordinate in order to make this happen in the appropriate time frame. This, what you see there, doesn't transmit very well, but the projection is a piece of clot that was actually withdrawn out of an artery, and the clot was occlusive to the artery. So here is an angiogram. Some of you may have seen these. You see where the arrow is on the left-hand panel is where the artery is closed, and where the arrow is on the right-hand panel, the artery has been reopened, flow has been restored, and there's a stent in there. So this is true for Kenosha's hospitals, but let me just say that this process is fairly unique. We developed this at a hospital system that I was working at before I came here, and at that time we were one of very few in the nation that had begun doing this, and I'll explain what this is. So historically, these procedures were done at the main Kenosha Hospital, and then when St. Catherine's was built, they began being done here. But typically, when a patient comes to the emergency room with a heart attack, and let's say they're brought in by EMS, EMS will bring the patient into the emergency room, tell the staff that there's somebody with chest pain. They'll do an EKG in the emergency room and make the diagnosis, and then decide on treatment and activating the cardiac cath lab team to see whether or not we want to open the artery. So that was a process. And the emergency room physician, by the time they went through all of this, that would probably be about 30 to 50 minutes spent in the emergency room trying to figure out what should be done, getting the administrative documents arranged before the patient could end up being taken to the cardiac cath lab, which of course might be a different scenario at 2 in the afternoon than it would be at 2 in the morning. At 2 in the afternoon, hopefully we have people here and available. At 2 in the morning, people have to come from home. It would be nice if they were living here, but that doesn't work so well. So what we decided to do, and now is being done at more centers, but not all, what we decided to do was to empower our emergency medicine colleagues. So we trust our EMS paramedics and EMTs to make the diagnosis in the field. Are they always right? No, but we're not always right either. So we're pretty happy with the fact that they can use the skill set that they have. They do an EKG pretty routinely in the field. So the ambulance comes, they hear a story of chest discomfort or something that leads them to suspect that the patient's having a heart attack. They do an EKG in the field, and once the EKG is done, if it resembles a pattern like that I suggested to you before, they will make a phone call to a single phone number, which is on this bag that each rig carries, and that phone number will activate to the emergency room here in the hospital, which will then lead to an immediate automatic EKG transmittal to the cardiologists by the internet. We get an email, and the team then gets activated automatically. Now, there are some caveats. There are certain circumstances where the team doesn't get activated. So let's say the patient has unstable vital signs, and instability is very much in the eye of the beholder. But if somebody is really, really, really sick with a heart attack, then we stabilize them in the emergency room. But if they are the garden variety heart attack, even if somebody has had ventricular fibrillation and been resuscitated, meaning if they've had sudden death and they've been shocked back to life, those people go directly to the cath lab without delay. And as a consequence, much of this is done in the field. So once the EMS crew knows that they're bringing the patient to the hospital, they have this little bag, and the bag contains things that they need for care of that patient that are specific to our system. And why do I say our system? Because any EMS agency that you would call in our immediate vicinity will bring the patient here, nowhere else. And that's an important message that I'm going to be trying to reiterate repeatedly. So we have partnered with our colleagues. We first began with Kenosha Fire. Maybe the same problem. Suggestion? So we first started with Kenosha Fire. Okay, that's good. And then expanded the program starting in late 2020. We expanded the program to all of the neighboring communities. So let me enumerate those places that we currently work with. We go as far west as Lake Geneva. Obviously, the lake is our eastern border. We include much of the collar communities in northern Illinois, especially with the demise of the Vista Hospital system. And part of, but not all of, Racine County. So everybody in Kenosha County, every EMS agency in Kenosha County, and agencies as far west as Lake Geneva bring every patient like this to us. There's a reason for that. And the reason they do that, and that's regardless of politics or patients' request, they do that because we are the only act in town, so to speak. If you transport a patient to another facility that doesn't have this available, the patient's heart muscle damage extends, becomes larger, and survival becomes lower. And so, for instance, one of the things that has recently become somewhat topical is there was a prominent member of the community who didn't understand all of this, a relatively younger person who probably never thought that a heart attack was in their future, and drove themselves to the emergency room across the street and was then, if I'm not mistaken, life-flighted by helicopter to Aurora St. Luke's. But try to imagine the amount of time involved in that. So think about that, folks. By the time you call for a helicopter, which comes out of, let's say, Milwaukee, it spools up, it takes off, it comes here, it lands, it spools down before you can load the patient, then it spools up, goes to Milwaukee, spools down. That's 2 hours no matter what the flight time is. You could drive much more quickly. But let's say you do that. By the time the patient arrives in the cath lab at another institution, let's say Aurora St. Luke's, probably an hour and a half has passed at the very least, and maybe more. So the problem with that is during that time, the heart's not getting any blood flow, and people die. And whatever they lose and doesn't get restored. So the EMS agencies recognizing that if you have a heart attack in the parking lot of the hospital across the street and EMS gets called, they will take you here. But if you walk into their emergency room on your own legs, you're in their system. And we don't want to talk about the politics of that or the economics of that. You can draw your own conclusions, but the point is that doesn't work. And it's clearly not what's in the best interest of patients. So we try to develop a plan that is very standardized. Not that one size fits all, but McDonald's works for a lot of people. So if you walk in, you know exactly what you're going to get. You know that this is what the team is going to do. The team knows what it's going to do. And everything is very standardized for the EMS agency people and for us. Again, sorry. So we have a little video, and maybe this. Yeah, that's okay. Hold to that, please. That's good. Yeah, that's great. So what we do as an after-action report, we invite our EMS colleagues to stay with the patient as long as they can take the rig out of service. And if they can, they watch the procedure being done, which helps educate them for the next time, helps create a bond between us and our colleagues. And as a consequence, I think we have a pretty well-oiled machine right now. When we're finished, this is a report that EMS gets. So there are metrics in the boxes that you see up top talking about the times involved. How quickly did EMS arrive on the scene? How quickly did EMS get the EKG? How quickly did EMS make their transport? What did they do during the transport? When did they activate the lab? When did they let us know that the patient was coming? And then all the metrics of time once they're here. So everybody looks at everybody else's outcomes, and we all learn from that. And again, in a way to personalize it, you have the EKG of the patient that they transmitted originally up at the top. You have the physicians and staff members that participated in the procedure. So again, it's a good way of team building. Just more examples of the same kind of thing. So this is that bag that I'd mentioned before that contains many of the tools that are unique to us. So the electrode leads, we want them to shave the patient in the ambulance if they can, the defibrillator pads, everything that we want on the patient. Rather than using their equipment, they use our equipment. Okay, let's...
What is
realized you embedded this.
If you're experiencing a heart attack, we need to open your occluded artery as quickly as possible. The more
volume
time
up?
your heart is deprived of blood, the more damage. We save 50 minutes by empowering and entrusting our fire department colleagues to utilize their skills when they're treating an acute heart attack in the field. With rapid stabilization, the patient can be transported directly to the cardiac cath lab. Our unique Froedtert Pleasant Prairie Hospital straight to cath program saves time and lives.
So this is no longer accurate, of course. These are the agencies that sent to us, but now we are below the line into Illinois and out as far again as Lake Geneva. Oh, this is more. So this is where we are currently. So this is where we currently receive patients from. We don't get much from Racine, but Ascension, as many of you know, has fallen on hard times, and we're starting to see some input from Racine as well as from Vista and Waukegan. Our door-to-balloon times, I won't go through that. Our door-to-balloon times have improved dramatically. They have been cut down from typically 120 minutes a few years back, now progressively lower and lower door-to-balloon times. We're now averaging, I think, about 50 minutes from door to balloon, meaning to an open artery. And our first medical contact may not be what we would like it to be, very honestly. We would like it to be with the national standard of 90 minutes or less. But we are a victim of our own success, by which I mean the more successful we are in getting agencies to say, gee, you're the best act in town, we're going to you. Let's say Lake Geneva, for instance. So the transport time from Lake Geneva is quite long. It's quite a bit longer than if somebody has a heart attack in Kenosha or Pleasant Prairie. So that adds time to the first medical contact to balloon. But on the other hand, we get advance notice because as they're driving, we're coming in. So it works both ways. But we are a victim of our own success. We're doing well enough that so many places want to transport their patients to us that we are seeing some stabilization of the first medical contact to balloon transport time. The message that I think I want to convey most importantly is, you might want to play that full video that we had. The message that I want to convey is that if we can get the artery open promptly, that's the best outcome for the patient. And you know, when you see on TV an ad that says 9 out of 10 dentists recommend, well, 10 out of 10 EMS agencies recommend coming here. So that is not an unarguable, unassailable point of view. It's not a selling point. It's just they know what is right and what is not right. Patients don't always know that. So patients need to be educated. If you have chest pain, even if you think it's unlikely that you're having a heart attack, but it might be, call EMS, don't drive yourself. They'll give you the right care at the right time and bring you to the right place. How about playing the full video? Maybe this would be a good time to do that. I sent you a couple of other small slides. So this has been pretty effective. We see about somewhere between 60 and 100, it's variable of course. We see about 60 to 100 heart attacks of this type per year. Please understand that this specific type of heart attack is a STEMI. There are many other heart attacks that are not STEMIs that are considered somewhat lower risk and not as urgently in need of attention. So there are other people who get lesser care, or at least more elective care rather than rushed care. But for this population, time is everything. And if you get the artery open quickly, the patient's survival will be benefited significantly. You all set? No? We have a video for you to watch, which is a little bit more of an expansion of the video that we had before. While we're waiting, any questions or comments as we go? Yes, ma'am.
If somebody has or thinks they're having a heart attack, they call the EMTs, they're in the ambulance, but they're not really capable of speech and talking. Is it up to the EMTs to make the decision as to where to take that patient?
Okay, so as it stands right now, there's a couple of caveats, but in that scenario, if any of those agencies that we talked about, any agency in Kenosha County and Lake Geneva or any of those Collar, Illinois counties, that would be automatic. Whether you want to go here or don't want to go here, unless you protest dramatically, you're coming here. So they won't give you an alternative. And they will give you, if you're able to converse with them, they'll give you an explanation of why. Many people think, well, my insurance is through Aurora's system, and therefore, if I go to Aurora, I won't be stuck with such a high bill. But that's not true. Under emergency circumstances, they're obligated to go to the closest facility that has the appropriate services. And we're the only act anywhere near town. The closest place other than us is in Milwaukee. There was a period of time when Ascension was doing this, but again, I think that things are changing there. So having said that, they want, in the circumstance that you describe where somebody is not capable of communicating, they'll of course only bring you here. Even if you were capable of communicating, they would bring you here.
Hello, everyone.
Yes.
EMS comes and they determine that it's a STEMI, but the anticipated delay, like for distance or whatever, like you described, that will they preemptively administer clot busters?
That's a great question. So the answer is no. That was true for a period of time in Europe, in the Scandinavian countries. That was true for a period of time. That went away. And the reason it went away is because the clot busters not only dissolve clot where you want them to dissolve clot, they make you bleed where you don't want to bleed. So with the clot busting drugs, there is a 3 or 4% incidence of a cerebral hemorrhage. A cerebral hemorrhage is the worst kind of stroke that you can have. It's not just a stroke, it's a stroke on steroids. And so the idea of doing that is unattractive to us. If the circumstances are very unique, in other words, if somebody is in extremis from a cardiac perspective and there is no other alternative, there are still places that do that. There are places that administer half of a dose of a clot buster during transport to get you to the full Monty. That really has died on the vine. It's not an effective strategy. So the current guidelines are that if you can get a patient to a heart attack center within 120 minutes or less, that should be your goal. And of course, less is more. So if you can get them there within 15 minutes, all the better. We do sometimes have door-to-balloon times of 10 and 15 minutes. That does happen. But, you know, the stars all have to be perfectly aligned for that to occur. Good question. Go ahead.
My name is Mike Rosenberg. I'm the department chairman for cardiovascular services here at Prairie South. I'm an interventional cardiologist. This month is Heart Month, and it's a good opportunity for everybody to think carefully about their heart health, a good opportunity to eat wisely, but we're here to let you know that we have some services should things not go the way that you would like them to, where we can help you if you're in a jam. Those services include the only direct to cardiac cath lab heart attack program in this vicinity, multiple counties. Kind of a unique situation where we really shave minutes off of heart attack care. What we do is we enable and empower our firefighting colleagues in EMS for all the agencies in the Kenosha County area and much of northern Illinois to bring their patients directly from the field to the cardiac cath lab should they be having a straightforward, significant event like heart attack. Those people then get their treatment more quickly, their arteries are opened more promptly, and this saves both lives and heart muscle functionality improvement. So this is something that is relatively unique. Not many hospitals in the country have adopted this program, although more are doing so over time. We've been doing this now for 3 years, and we've seen dramatic success with about a 45 to 50 minute time benefit to opening up a closed artery, which is, of course, life-saving.
So, I don't know that going through the statistics, which are out. I don't know that going through the statistics that I have on the slides is appropriate because they're 3 years out of date, and I did not update them. But I think that what I've pretty much told you is correct. It is about a 50-minute savings in time, no matter how we approach it. That does translate into heart muscle, so that's important. And the outcomes are very good. We're doing, as I say, somewhere between 60 and 100 of this type of heart attack every year. And we think that those numbers are only going to continue to grow. So please, the one thing I would ask you to encourage any of your friends and neighbors is should they think that they're having a cardiac event, call EMS. Do not drive yourself, please. EMS will be able to treat whatever eventuality occurs en route, and sometimes that happens. So sometimes on your way here, if you have ventricular fibrillation and you're in your car, that's not a good place for you to be resuscitated. Call EMS and have confidence that they will make the right choices. In this case, for this type of problem, they will bring patients only here. Questions or comments?
Prior to this program starting, I had an actual family member, I don't think I've shared it with you. My uncle had a STEMI and he went, in an ambulance across the street. Unfortunately.
Come up a little louder. It's hard to hear you. Go ahead.
That's all right. So I'm just going to share a little bit. I'm the manager of interventional procedures, so I work really closely with Dr. Rosenberg and the other cardiologists. I have a personal story of my uncle a few years prior to this program starting, developed chest pain in the middle of the night, was picked up by EMS. They requested to go to a different facility within the Kenosha area. He was having a heart attack, was a STEMI. However, he had to wait for flight to come, be transferred, go through the procedure. And as Dr. Rosenberg has said, every minute that you're saving is the muscle is dying. The end result is, yes, they were able to stent, but he lost a lot of heart function, never recovered from that. Subsequently had a lot of other health issues then that followed because his heart muscle was not saved in time. So
what's interesting, to amplify what Judy said, is that when we talk about the vigor with which the heart squeezes, a normal ejection fraction, that's a measure of the vigor of squeeze, is 55 to 60%. And following a heart attack, especially a large heart attack, a lot of that territory is damaged, and some of it, we hope, is reversibly damaged, and some is irreversibly damaged. So if we restore flow quickly, the heart muscle may be stunned for a period of time, but then often recovers. And it is not at all uncommon for us to see victims of a front wall heart attack that has often been called the widowmaker come back a week later, 2 weeks later, and their heart muscle function is perfectly normal, and you can't tell that anything bad happened. So that happens a lot, and is something that makes us very proud and very excited and makes patients very happy. But the longer the time the wavefront continues, the less likely that is. So what you then see is what you end up with long term. And that can be a significant debility for patients. Shortness of breath, congestive heart failure, cardiac rhythm disturbances of certain types. It's a bad gift to confer on anybody. Thank you for those comments, Judy. Anybody else? Yes, ma'am.
Alcohol heart attacks are eligible for the stemming procedure.
Correct.
And how do they decide? They just decide.
I don't know if this is working, but is it? No? Oh. Go ahead. Sorry.
No, I just wondered.
How do we decide which heart attacks are?
Yes,
Okay.
yes.
So you're correct. What was asked is what kind of heart attacks are eligible for this? So we, in the universe of heart attacks, many people have what is called a heart attack, but is not what we're talking about here. So those are typically more minor. Think of them as incomplete heart attacks or partial thickness heart attacks. Maybe that's a simpler way of looking at it. The ones that we're talking about here are the major sudden artery is closed, there's no flow, that territory is undernourished acutely, and that territory dies. The other type of heart attack, generally speaking, is something called a non-STEMI. So these are STEMIs, that's ST elevation myocardial infarction. Everything else falls into the non-STEMI group. Acutely, those types of heart attacks have a much lower morbidity and mortality, whereas this has a much higher upfront morbidity and mortality.
And then if a person is a DNR patient, they would not be eligible or something like that.
So that's a great question. And the answer is a little bit more complex than simple. So generally speaking, DNR means different things to different people. I know what it means to me. Everybody needs to decide for themselves what it means to them. But in order to do any kind of life-saving procedure, if a patient is DNR, that has to be suspended before the procedure is done. And when I say suspended, that means with forethought. In other words, many people have the idea, I don't want what would be interpreted as futile care. That's not the same thing as being DNR. I don't want futile care for me, but I'm not DNR. I don't want somebody to be doing things that have very little likelihood of improving my quality of life or extending my life. That would be considered futile care. So I wouldn't want that. But for somebody who's DNR, there are different factors that bring that to the table. So somebody could be DNR because I really don't want to go through anything, but if I could be restored to where I was yesterday, yes, please do it. All depends on the presentation, but a good question. Well, if there are no other questions, please, again, my most important take-home message to you is EMS is wise. They are well-trained. They are good partners. We trust them. Most hospitals don't, and that's to their loss and to the loss of patients. That's why these programs tend to be very quickly adopted by EMS and tend to be so very effective, because we trust our partners, and you should trust them as well. So if you have something that seems like it's heart-related and is a little bit frightening, assume the worst and know that if you call EMS, you'll get to the right place in the right fashion, and your survival chances are much, much, much greater. And know that they will be honest brokers, that they will do what is right for you. Sometimes we make emotional decisions that are not necessarily so sharp. So tell your friends, don't drive yourself to the hospital. Call EMS. Thank you for your attention, folks.
Thank you.